Chapter 59, Caring for Clients with Disorders of the Bladder and Urethra. This is from Timby MedSurg. Again, Chapter 59. Learning objectives. 1. Explain urinary retention and appropriate nursing management. 2. Discuss urinary incontinence and appropriate nursing management. 3. Describe the pathophysiologic changes in cystitis, interstitial cystitis, and urethritis. 4. Explain the symptoms associated with bladder stones. 5. Discuss the cause and treatment of urethral strictures. 6. Describe the treatment and nursing care for a client diagnosed with a malignant bladder tumor. 7. Describe various types of urinary diversion procedures. And 8. Identify components of a teaching plan for a client having a urinary diversion procedure. Acute urinary retention that is likely to resolve quickly, such as after anesthesia, probably will be treated by intermittent catheterization. Clients with acute retention are unlikely to resolve without surgical intervention. In other words, an example would be retention caused by an enlarged prostate and probably will have an indwelling uterine catheterization done. Nurses measure the volume of urine in the bladder with a bedside scanner to help determine if the catheterization is needed. If required, the nurse collaborates with the physician to determine if the catheter is to be left in place or removed after the bladder is emptied. The nurse selects the size and type of catheter, sometimes consulting the physician if there are special circumstances such as an enlarged prostate. Catheters are sized according to the French system, 14 French to 24 French. The higher the number, the larger the diameter of the catheter. The CDC recommends selecting the smallest catheter in order to avoid trauma to the urethra and the bladder neck. Clients with an obstruction may be more easily catheterized with a Coude catheter. The curved tip slides over obstructing tissues more readily than the straight-tipped catheter. The nurse selects the appropriate catheter and inserts it under sterile conditions, noting the characteristics and volume of urine returned. If the volume of urine is larger than 700 mils, it may be necessary to clamp the catheter before the bladder has emptied to prevent bladder spasms or loss of bladder tone. If the client is going to be managed by CIC, which is intermittent catheterization, the client and the nurse establish the schedule. The bladder, in this case, should not be allowed to get distended beyond 350 milliliters because bladder over-distension results in loss of bladder tone. Chronic urinary retention. Chronic urinary retention may go unrecognized. The nurse should ask all clients during an initial health assessment about voiding frequency, the amount, small, moderate, or large, of urine passed each time, the presence of pain or discomfort in the lower abdomen, pain or discomfort on voiding, and difficulty in starting the urinary stream. The examiner gently palpates or percusses over the lower abdomen to determine if the bladder is distended. After asking the client to void, the nurse will scan the client's bladder to measure the amount of urine left. In addition, the nurse obtains a complete medical drug and allergy history and reports suspected chronic urinary retention. And then a decision will be made about how best to drain the bladder. The ultimate goals are to safely empty the bladder and prevent infection to the urinary tract. Assessment findings include complaints of urgency, frequency, leaking small amounts when coughing or sneezing, or complete inability to control urine, depending on the underlying cause. Tests such as a urine culture and sensitivity, cystoscopy, cystogram, urodynamics, and or pelvic ultrasound are used to determine the type of incontinence. Medical and surgical management. Treatment is aimed at correcting the disorder causing the incontinence when possible, providing medication to control incontinence, correcting the situational problems that contribute to functional incontinence, or instituting a bladder retraining program. Drugs that can improve bladder retention, emptying, and control include anticholinergic drugs such as oxybutynin, which is known as ditropan, which reduces bladder spasms and involuntary bladder contractions, Detrol, with similar action, and dibenzoline, which may be useful in treating problems with sphincter control. Urethral helps to increase contraction of the detrusor muscle, which assists with emptying of the bladder. Alpha blockers such as tamsulosin or Flomax may be prescribed for males. These medications promote relaxation of the bladder neck muscles and the muscle fibers of the prostate gland, easing the client's ability to empty the bladder, thus reducing incontinence. Some tricyclic antidepressant medications, Elavil, Pamelor, and Ascendin, are useful in treating incontinence because they decrease bladder contractions and increase bladder neck resistance. Pseudoephrine or Sudafed may help stress incontinence. Estrogen can be useful in restoring mucosal, vascular, and muscular integrity of the urethra for postmenopausal women's incontinence, but treatment may only be effective for about a year. Sometimes medication to control incontinence results in retention and must be discontinued. Occasionally, clients who can easily perform an intermittent catheterization may opt for medicine-induced retention and intermittent catheterization because it allows them to stay dry. Biofeedback uses electronic devices or diaries to assist clients to track when the bladder and urethral muscles contract in order to gain more control. There are other devices that can augment weak pelvic muscles. A urethral insert is similar to a disposable tampon device that the client inserts into the urethra before engaging in activity that contributes to stress incontinence. A pessary is a stiff ring that a healthcare provider places in the vagina to prevent urine leakage. It is commonly used for clients who have a prolapsed bladder or uterus. Surgeries and other procedures to improve urinary control include the following: bladder augmentation, a procedure that increases the storage capacity of the bladder by transplanting a section of the intestine or stomach into the top of the bladder. Periurethral bulking, placement of small amounts of collagen in urethral walls to aid the closing pressure. Injection of Botox into the bladder muscle, sometimes used for clients with OAB, otherwise known as overactive bladder. These would be clients who anticholinergics have not worked. This treatment helps the bladder to relax. This is the Botox treatment, increasing the storage capacity of the bladder and reducing incontinence. Treatments can be repeated every 3 months. Implantation of an artificial sphincter that can be inflated to prevent urine loss and deflated to allow urination. Surgeries to provide better support for urinary structures such as retropubic suspension. It's an open abdominal procedure that involves lifting and anchoring the bladder and urethra to the pelvic wall through the vagina, usually done in conjunction with other open abdominal surgeries such as a hysterectomy. Anterior repair is a procedure that increases support to the bladder by tightening the vaginal wall under the urethra. Transvaginal needle suspension is a procedure in which the bladder and urethra are attached to the pubic bone or fibrous tissue of the rectum through incisions. Sling procedures, a procedure in which a small vaginal incision is used to place a piece of synthetic or natural tissue material under the bladder neck. It is secured to the abdominal wall or pelvic bone to create a hammock type of lifting of the urethra. Sacral nerve stimulation implantation is implantation of a small device similar to a pacemaker that acts on nerves that control bladder and pelvic floor contractions. It is implanted under the skin in the abdomen. A wire connected to a sacral nerve emits electrical pulses to stimulate the nerve and help control the bladder. The client does not experience pain and is relieved from heavy leaking in many cases. Surgical correction also of anatomic problems, and urethroplasty, which is surgery to repair structures damaged by trauma. Nursing management with urinary incontinence includes maintaining continence as much as possible, preventing skin breakdown, reducing anxiety, and initiating a bladder training program. Instructions on exercises to increase muscle tone and voluntary control, called Kegel exercises, should be taught. Also techniques to assist bladder emptying and bladder training. Is the following statement true or false? The customary solution for urinary retention is developing a permanent drainage system. True. The customary solution for urinary retention is developing a permanent drainage system. In men, surgery is indicated. In women, a permanent indwelling catheter is utilized. Urinary incontinence, the pathophys and etiology is problems with the bladder, urethral dysfunction, failure of urethral sphincters to hold urine. Assessment findings are client complaints. Diagnostic findings determine the type of incontinence, and method and surgical management of treatment and medicines depend on the problem and also if surgery is needed or requested. Cystitis, the path and phys of this is inflammation of the urinary bladder. The bladder irritation causes incontinence. Assessment findings are the signs and symptoms of a bladder, a UTI. The cystitis is usually caused by a bacterial infection. Because the urethra is short in women, ascending infections or microorganisms from the vagina or rectum are more common. Causes of cystitis include urologic instrumentation, such as cystoscopy and catheterization, fecal contamination, prostatitis or benign prostatic hyperplasia, indwelling catheters, pregnancy, and sexual intercourse. There are times that cystitis occurs as a reaction to some drugs, radiation therapy, or irritants, such as feminine hygiene products or spermicidal gels. Diagnostic findings. Microscopic examination of the urine reveals an increase in the number of red and white blood cells. Culture and sensitivity studies are used to identify the microorganism and the appropriate antimicrobial therapy. If repeated episodes occur, an IVP or cystoscopy with or without retrograde pileograms may be needed to identify the possible cause, such as chronic prostatitis or a bladder diverticulum, which is weakening and outpouching of the bladder wall, which encourages urinary stasis and infection. Medical management includes antimicrobial therapy and correction of the contributing factor. Antibiotics most frequently prescribed for UTIs include Cipro, fosmicin, levofloxacin, nitrofurantoin, and an antibiotic combined with a sulfonamide, which is sulfathiaxole trimethoprim. Adjuvant drugs may be used, such as phenazapyridine, which works like a local anesthetic to reduce bladder discomfort. Methenamine may be added when long-term management of a recurrent UTI is required. Nursing management for cystitis includes advising the client to drink extra fluids. As stated earlier, cranberry juice may provide a less favorable climate for bacterial growth, but research has not fully demonstrated this. It's important to emphasize the importance of finishing the prescribed course of therapy, and the nurse also instructs the client in the prevention of repeated cystitis. True or false? To treat cystitis or a bladder infection, ingestion of cranberry juice or vitamin C is recommended. This is true. To treat cystitis, bladder infection, ingestion of cranberry juice or vitamin C is recommended. The acid creates an environment within the bladder that is hostile to the development of pathogenic microbial growth. So the rationale behind the science is that it cannot prove that drinking cranberry juice is effective in treating the bladder infection, but it also cannot substantiate that it does not help. So therefore, the nurse is going to advise to drink the cranberry juice and take vitamin C. Interstitial cystitis, painful bladder syndrome. Pathophysiology and etiology. Interstitial cystitis, IC, painful bladder syndrome, PBS, is a chronic inflammation of the bladder mucosa, causing pain in the bladder and surrounding pelvic region. Eventually, there is disintegration of the bladder lining and a loss of bladder elasticity. IC varies greatly in presenting symptoms, and thus the PBS designation is added to include all painful urinary symptoms that do not strictly meet the criteria for IC alone. It is more common in women than men. The bladder wall contains multiple pinpoint hemorrhagic areas that join and form larger hemorrhagic areas that may progress to fissuring and scarring of the bladder mucosa. Superficial erosion of the bladder mucosa, Hunner's ulcer, may develop, HUNNER''S. Eventually, the bladder shrinks from scarring. The cause of IC-PBS is unknown, but there may be a hormonal link because flare-ups appear to occur before menstruation. The possibility of a defect in the epithelial lining of the bladder may contribute to the problem. Another theory is that IC-PBS may be an autoimmune disorder or part of a systemic condition because some persons have a history of migraine headaches, ulcerative colitis, irritable bowel syndrome, endometriosis, fibromyalgia, or chronic fatigue syndrome. Assessment findings. Symptoms mimic other disorders such as cystitis, bladder cancer, or a sexually transmitted infection, STI. Frequent painful urination and passing a small volume of urine are the most common symptoms. The pain may be described as searing or burning. The client reports an onset of pain and the need to void as soon as a small amount of urine is present in the bladder. Many clients report painful intercourse. Cystoscopy reveals a markedly inflamed bladder mucosa with pinpoint hemorrhages and a bladder capacity that is smaller than normal. Filling the bladder during cystoscopy to improve visualization usually results in severe pain. Avoiding cystourethrogram also demonstrates a small bladder capacity. Results of urinalysis usually are normal, but if cystitis is present, an increase in the number of red and white blood cells may be seen. Urine cultures are negative. A record of the number of voidings and the amount voided over a 2 or 3 day period, along with the symptoms, help to confirm the diagnosis. A biopsy of the bladder mucosa reveals an inflammatory process with scarring in hemorrhagic areas and confirms the diagnosis. Sometimes a potassium sensitivity test is done. With this test, the examiner first instills water into the bladder. After the water is removed, a potassium solution is instilled. If the client experiences more pain and urgency with the potassium solution, IC-PBS may be diagnosed. Clients who do not have IC-PBS cannot distinguish the difference between the water or potassium solution. Medical and surgical management. There is no single effective specific therapy for IC-PBS. Non-steroidal anti-inflammatory drugs, NSAIDs, are used to relieve pain. Almiron pentosan polysulfate, a bladder protectant, is the most effective medication. It provides relief of the bladder pain associated with IC. Tricyclic antidepressant drugs such as amitriptyline, Elavil may also relieve pain as well as treat the depression that can accompany the disorder. Antihistamines are sometimes prescribed to reduce urinary frequency and urgency. Other therapies include bladder instillation of dimethyl sulfoxide, DMSO, while other solutions are being tested. Other treatments include the following. Bladder distension. Some clients report relief after an instillation is done as part of the diagnostic process. Relief is initially transient but then returns within 2 to 4 weeks. It is theorized that stretching the bladder increases capacity and interferes with pain transmission. Bladder distension can be done with water or gas and can be repeated. Transcutaneous electrical nerve stimulation, TENS. Wires are applied to the lower back or suprapubic area. It is theorized that the electrical stimulation increases blood flow to the bladder, strengthens pelvic muscles, and/or triggers the release of endorphins to block the pain. In some cases, urinary frequency is reduced. Urinary diversion procedure, discussed later. For those clients for whom severe IC-PBS can be incapacitating, it may offer the only relief of symptoms for a selected group of clients. Nursing management. The nurse advises the client to avoid spicy and acidic foods because they may contribute to pain and discomfort. Some clients obtain relief by omitting carbonated beverages, caffeine in all forms, citrus products, and foods with high concentration of vitamin C. Psychological support is necessary because many times IC-PBS has gone undiagnosed and the client has been told that there is nothing wrong. Clients with IC-PBS often have their lives severely disrupted by pain and frequent trips to the bathroom, sometimes several times an hour. Some clients are unable to hold jobs because of the severity of symptoms. Sexual activity is avoided because of fear of pain, straining the relationship and interfering with intimacy. Clients should be referred to a chronic pain center to cope with the pain and to an IC-PBS support group. Urethritis, which is inflammation of the urethra, is caused by microorganisms including gonococcus, chlamydia, trachomonas infection, more common in women than men. Gonorrhea can cause this type of infection. In women, urethritis may not only accompany cystitis, but may be secondary to vaginal infections. Soaps, bubble baths, sanitary napkins, or scented toilet paper also may cause urethritis. In men, a common cause of urethritis is infection with chlamydia or urea plasma urethriticum, which causes an STI. The distal portion of the normal male urethra is not totally sterile. Bacteria that normally are present cause no difficulty unless these tissues are traumatized, usually after cath or cystoscopy examination. Bacteria may gain a entrance and cause nonspecific urethritis. Other causes in men include irritation during vigorous intercourse, rectal intercourse, or intercourse with a woman who has a vaginal infection. Assessment findings. Infection of the urethra results in discomfort on urination, from a slight tickling sensation to burning or severe discomfort and urinary frequency. Fever is not common, but fever in the male client may be owing to further extension of the infection to areas such as the prostate, testes, and epididymis. There may be urethral discharge and itching in the urethra. The client's history and symptoms often provide a tentative diagnosis. In men, a urethral smear is obtained for culture and sensitivity to identify the causing microorganism. In women, a urinalysis may identify the cause of the microorganism. Medical management includes appropriate antibiotic therapy, liberal fluid intake, analgesics, warm sitz baths, and improvement of the client's resistance to infection by a good diet and plenty of rest. If urethritis is owing to an STI, it is treated with appropriate antibiotic therapy. Failure to seek treatment for gonococcal urethritis may result in a urethral stricture in men. Nursing management. The nurse reinforces the need to complete antibiotic therapy, drink plenty of fluids, take warm sitz baths, and analgesics for pain. Urethritis may be seen in clients with indwelling urethral catheters. To prevent or decrease this, the nurse needs to be vigilant with sterile technique as well as to exercise gentleness when changing catheters. It is also essential to provide frequent perineal care, especially if the client is incontinent of feces. In addition to washing around the anus and buttocks, the nurse also cleans the meatus and labia of the female client. When cleaning the anal area, wipe away from the urethra, ensures that there is no contamination. If cotton pads are used, the nurse wipes from the urethral meatus to the anus in a single stroke and discards the pad. Client teaching is included in the nursing process section in TIMBY, page 1109 and 1110. Bladder stones. The path and phys for this is a formation of stones. Stones may form in the bladder or originate in the upper urinary tract and develop and remain in the bladder. Large bladder stones develop in those with chronic urinary retention and urinary stasis. Prostate gland enlargement can lead to bladder stones because the prostate gland impedes urine flow through the urethra, resulting in urinary stasis. Clients who are immobile, the unconscious client, or those with paraplegia or quadriplegia also may have a tendency to form bladder stones. Signs and symptoms include hematuria, cloudy or dark urine, suprapubic pain, difficulty starting the urinary stream, symptoms of a bladder infection, and a feeling that the bladder is not completely empty. Some clients experience pain with voiding. Other clients may have few or no symptoms. A UA is done to rule out infection. A spiral CT scan is done to determine the presence of stones. Even very small stones can be detected. Cystoscopy, a kidney ureter bladder KUB test, IVP, or ultrasound studies can also detect the presence of bladder stones. Blood chemistries and 24-hour urine collection for serum calcium and uric acid may identify the cause of the stone formation. Bladder stones can be removed through the transurethral route using a stone crushing instrument, the lithotrite. This procedure is called a cystolithoplasty. It's suitable for small and soft stones. It's performed under general anesthesia. Large, non-crushing stones must be removed surgically, but this is effective for the smaller stones. Low purine diet is recommended, which includes avoiding meat and poultry, crab, lobster, oysters, and shrimp, and limiting your intake of vegetables to a half a cup each day. High purine foods are anchovies, sardines, scallops and mussels, tuna, codfish, herring, and haddock, wild game meats, organ meats, gravies and sauces made with meat, and yeast extracts taken in the form of a supplement. Clients with a history of calcium oxalate stone formation need a diet that is adequate in calcium and low in oxalate. Foods that contain high levels of oxalate that you're going to tell your patient to avoid include peanuts, rhubarb, spinach, beets, chocolate, and sweet potatoes. They can still have calcium-rich foods, but not the oxalate-rich foods. Nursing management need to completely assess the patient and also do a complete medical family, drug, and allergy history, asking the client to describe the symptoms, including the type and location of the pain. You need to monitor vital signs every 4 hours. Notify the doctor if the temp is higher than 101 Fahrenheit. INO and the color of the urine are documented in the medical record. If there's any evidence of blood in the urine, the nurse reports it immediately. You need to encourage the client to drink fluids unless contraindicated by heart failure or renal disease. And this is important because extra fluids can help pass stones and reduce the chance of infection or inflammation. The nurse filters the urine for stones by straining all urine through gauze or wire mesh. If solid material is found, it is sent in a labeled container to the lab for analysis. If the client has moderate to severe pain, the nurse administers an opioid analgesic. If the analgesic fails to relieve at least some of the pain, or if the pain becomes worse despite this, the nurse notifies the provider and provides details regarding the effects of medical or surgical procedures. If the cystolithoplasty was used, this usually removes the stone. A ureteral catheter may be left in place to keep the bladder continuously empty for 1 to 2 days after the procedure. You're going to give antibiotics as ordered, oral fluids as tolerated, and it is important to encourage the client to drink extra fluids to reduce inflammation of the bladder mucosa. In addition, the nurse monitors the INO and the voiding pattern. If open removal is required, the bladder is incised and the stone is removed. A ureteral catheter may be left in place for a week or more to keep the bladder empty and prevent tension on the bladder sutures. In addition to standard postoperative care, nursing management involves providing the same care as the client who's having a suprapubic prostatectomy, Chapter 55. The nurse closely monitors the client's voiding once the catheter is removed to prevent urinary retention. Urethral strictures. This is due to infections or trauma or congenitally acquired. This is a narrowing in the urethra that obstructs the flow of urine and can cause complications in the bladder or upper urinary tract. The ureters may become distended with urine as a result of the obstruction, and the kidney can also become, pelvic part of the kidney can also become distended with the backflow of urine. Signs and symptoms include slow force of urine, hesitancy, dysuria, and urine retention in the bladder, and nocturia. Diagnostic findings can be done with a cystoscopy, an IVP, a retrograde pyelogram. Medical and surgical management is dilation and urethroplasty. Bladder malignancies, or bladder cancer. Bladder cancer is a frightening diagnosis for clients. Bloody urine often is the first sign of a problem and the reason clients seek medical attention. Pathophysiology and etiology. Bladder cancer is the most common cancer in the urinary system. It occurs more frequently in men than in women and usually affects clients 55 years of age or older. The American Cancer Society, as of 2016, estimates that 1 in 26 men in the U.S. will be diagnosed with bladder cancer, as opposed to 1 in 88 women. Use of tobacco products as the leading cause of bladder cancer. The following list includes environmental and occupational health hazards thought to be associated with bladder tumors. Cigarette smoking and secondhand smoke. Smokers and those exposed to frequent secondhand smoke are 3 times as likely to develop bladder cancer. Exposure to environmental carcinogens such as dyes, paint, ink, leather, or rubber. Certain occupations increase the risk for developing bladder cancer. Hairdressers, exposure to hair dyes. Machinists, exposure to multiple chemicals and fumes. And truck drivers, exposure to diesel fumes. Recurrent or chronic bacterial infections of the urinary tract. Arsenic in drinking water. Bladder stones. Insufficient intake of fluids. Bladder birth defects. Family history. High urinary pH. High cholesterol intake. Pelvic radiation therapy or chemotherapy. Cancers arising from the prostate, colon, and rectum in men. The most common type of bladder cancer is transitional cell carcinoma or urothelial carcinoma, which develops in the bladder's epithelial lining. The tumors are classified as papillary or non-papillary, flat. Papillary lesions are superficial and extend in finger-like projections outward from the mucosal layer. These tumors are considered non-invasive. Non-papillary tumors are solid growths that grow inward, deep into the bladder wall. This type is more likely to metastasize, usually to the lymph nodes, liver, lungs, and bone. Other types of bladder cancer include squamous cell carcinoma, adenocarcinoma, small cell carcinoma, and sarcoma. These types account for less than 5% of all bladder cancers. Signs and symptoms. The most common first symptom of bladder cancer is painless hematuria. Clients may notice a change in the color of their urine and then will not notice any difference. This can occur off and on for quite a long period of time. However, hematuria will always recur in clients with bladder cancer. Additional early symptoms include those related to a UTI, with symptoms such as fever, dysuria, urgency, and frequency. Later symptoms are related to metastasis and include pelvic or lower back pain on one side, urinary retention if the tumor blocks the bladder outlet, and urinary frequency from the tumor occupying bladder space. There's also loss of appetite and weight loss, weakness, swelling in the feet, and bone pain. If bleeding is present for a period of time, the client may also experience symptoms of anemia, fatigue, shortness of breath caused by blood loss. Diagnostic findings. The tumor usually is seen by cystoscopy examination and confirmed by microscopic biopsy. Blue light fluorescence cystoscopy is frequently done because it improves the detection of cancer. This test uses a photosensitizing drug in combination with blue light cystoscopy. The drug is instilled into the bladder, remaining there for at least an hour. The drug is absorbed by cancer cells, which then can be visualized with the use of the blue light. Abnormal cells are fluorescent red. Normal cells appear bluish green. The examiner has a clearer picture of the extent of the malignancy. A retrograde pileogram may be obtained to detect any kidney damage if the tumor is obstructing one of the urethral orifices. A computed tomography or CT scan with guided needle biopsy, MRI, and X-rays of the pelvis may show a tumor shadow or bony metastasis. A bone scan may also be done. Ultrasonography may be done to determine tumor size and location. Routine laboratory tests are performed to evaluate kidney function and determine the degree of anemia owing to persistent hematuria. Urine cytology and urine tumor marker tests are done to determine if there are cancer cells in the urine. Medical management. Treatment varies according to the grade and stage of the tumor. Metastases usually have not occurred as long as the tumor has not penetrated the muscle wall of the bladder. Small superficial tumors may be removed by cutting, resection, or coagulation, fulguration, with a transurethral resection of a bladder tumor, abbreviated TURBT. Bladder tumors removed in this manner have a high incidence of recurrence. Consequently, a cystoscopy examination is performed every 2 to 3 months. Clients having no reoccurrence of the tumor for at least 1 year require cystoscopy examinations every 6 months for the rest of their lives so that reoccurrence of the tumor or a new malignant growth can be detected early. Topical application of an anti-neoplastic drug may be used after a TURBT. A liquid form of the drug is instilled into the bladder by means of a catheter, intravesicular injection. Fluid intake usually is limited before and during this procedure so that the drug remains concentrated and in contact with the bladder mucosa for about 2 hours. The client then voids and is given extra oral fluids to flush the drug from the bladder. Intravesicular injection of Bacillus calmette-guerin BCG live, a weakened strain of Mycobacterium bovis, also may be used. It appears that BCG causes an inflammatory reaction in the bladder wall that in turn destroys malignant cells. Another form of therapy includes the administration of interferon alpha 2A, roferon A, injected intravenously IV or directly into the bladder. Interferon appears to stimulate the production of lymphocytes and macrophages that may destroy malignant cells and may be used in combination with BCG. Mitomycin, a chemotherapeutic vesicant agent, may be used as well. It's also injected via catheter into the bladder. The effects of mitomycin appear to improve when the bladder is heated, referred to as electromotive mitomycin therapy. Other drugs that may be used are valrubicin, docetaxel, thiotepa, and gemcitabine. Photodynamic therapy may also be used in the treatment of bladder cancer. This experimental treatment involves an IV injection of a photosensitizing agent that is absorbed in concentration over several days by malignant cells. A laser inserted through a cystoscope activates the drug so that it can destroy the malignant cells. Radiation therapy may be used for clients who do not have the whole bladder removed. The goal is to eradicate any remaining cancer cells. Surgical management. The clinical stage of the bladder cancer determines if surgery is done as part of the treatment. A partial or segmental cystectomy, which is a surgical removal of part of the bladder, may be done if the tumor is confined to a small area and is not large. A radical cystectomy, total removal of the bladder, and a urinary diversion procedure often are necessary when the tumor has penetrated the muscle wall. When a cystectomy is performed, the bladder and lower third of both ureters are removed. If the tumor has extended through the bladder wall, the surgeon may perform a radical cystectomy. In women, a radical cystectomy usually involves removal of the bladder, lower third of both ureters, uterus, fallopian tubes, ovaries, anterior vaginal wall, and urethra. In men, a radical cystectomy usually includes removal of the bladder, lower third of both ureters, prostate, and seminal vesicles. Once a cystectomy is performed, urine must be diverted to another collecting system. This is called a urinary diversion. Although urinary diversion procedures are used for the treatment of bladder tumors, they are also used for extensive pelvic malignancies and severe traumatic injury to the bladder. Some urinary diversions require external ostomy bags to collect the urine, referred to as incontinent urinary diversions. See Figure 59.7. One option is to remove a short piece of the ileum and connect it to the ureters. With this technique, urine flows from the kidneys through the ureters into the ileal conduit. The distal end is formed into a stoma or urostomy. A collection or urostomy bag, called a pouch, collects the urine, which flows constantly. Other types of urinary diversions create a reservoir within the body, and the reservoir is catheterized to drain the urine. These are called continent urinary diversions. See Figure 59.7. In this type of urinary diversion, a piece of intestine is used to create a reservoir that is attached to the ureters on one end and to a stoma on the other end. A valve within the stoma is also created. The client periodically inserts a catheter to go through the valve into the reservoir and drains the urine. An external pouch is not needed with this method. A third method is referred to as neobladder, or a continent orthoptic bladder substitution. This technique involves taking a piece of the intestine to form a reservoir. It is connected to the ureters and then the urethra so that the client urinates normally. Some clients may experience incontinence, especially at night, but prefer this to other methods. Sometimes clients need to use a catheter to thoroughly drain the reservoir. Nursing management. The preoperative period. The nurse obtains a complete medical drug and allergy history on admission and asks the client or family members to describe all symptoms. The assessment also includes an evaluation of general physical and emotional status, vital signs, and weight. Caring for a client during the preoperative period includes reducing anxiety and increasing understanding of the preparations for surgery and post-op care. The client may display various emotional responses before surgery. Some may appear depressed, others show a mixture of anxiety and depression. The client faces drastic changes in the manner of excreting urine from the body, the diagnosis of cancer, and the changes in body image. The nurse encourages the client to talk about the surgery and the changes that will occur. He or she may suggest a visit from a member of the local ostomy group to provide emotional support as well as information. The wound ostomy and continence nurse, abbreviated WOCN, should meet with the client to discuss placement of the stoma and collection devices if applicable. Photographs or drawings are useful in showing the placement of the stoma and urostomy pouch. The nurse determines the client's ability to manage stoma care or self-catheterization by assessing manual dexterity, level of understanding, and vision. Assessing the client's social support and resources, including whether insurance will cover ostomy supplies, is important. The nurse explains all preoperative preparations to the client and family and gives them time to ask additional questions about the surgery, preparations for surgery, and management after surgery. Depending on the extent and type of surgery, preoperative preparations may include insertion of a nasogastric tube, placement of IV and central venous pressure lines, administration of cleansing enemas, and adherence to a low-residue diet several days before surgery. Laxatives and enemas and a drug such as kanamycin, Cantrex, or neomycin, mycifedrin may be given if a ureterosigmoid ostomy is to be performed. These agents decrease the number of microorganisms in the bowel and lessen the possibility of infection as a complication of connecting the ureters to the bowel. Clients scheduled for an ileal conduit or a continent urinary diversion procedure, see Figure 59.7, also may have the bowel prepared in this manner. Postoperative period. Clients undergoing urinary diversion are subject to the same conditions and complications as any surgical client. Refer to Chapter 14 for nursing diagnoses and interventions for managing standard post-op care. Management issues related specifically to urinary diversion procedures include observing for the leakage of urine or stool from the anastomosis, maintaining renal function, assessing for signs and symptoms of peritonitis, maintaining integrity of the urinary diversion and urine collection devices, maintaining skin and stomal integrity, promoting a positive body image, and teaching the client how to manage the diversion. The nurse checks the client's chart for information regarding the type and extent of surgery and orders for connection of catheters or drains, IV fluids, and analgesics. Clients will have multiple drainage tubes, urethral, stents, and a nasogastric tube. All urinary drainage tubes must be labeled, and the urine output from each catheter or stoma must be measured and recorded hourly. Maintaining adequate intake and output measurements during the post-op period is important because it indicates both renal function and the integrity of the urinary diversion structures. Obstruction of urine flow can severely damage the kidneys. If urinary drainage stops or decreases to less than 30 mL per hour, or if the client complains of back pain, the nurse needs to notify the physician immediately. Inspection of the urine includes checking for color, clarity, and presence of blood. It is essential to immediately report concentrated, cloudy, or bloody urine to the physician. Urethral stents remain in place for several days after surgery. The nasogastric tube is connected to low intermittent suction. This prevents distension and pressure on the suture line owing to the collection of gas in the bowel. The nasogastric tube is removed once peristalsis has returned and the diet can be advanced. All lab reports are reviewed as soon as they are received and abnormalities reported to the physician promptly. The following sections address management issues specific to the most common procedures. Ileal conduit. A transparent ostomy bag is applied over the stoma to make stomal assessment easier. The nurse contacts the physician immediately if there's excessive bleeding, changes in the color of the stoma from a normal to a cyanotic color, or separation of the stoma edges from the surrounding skin. The nurse uses gauze pads to clean mucus away from the stoma. Because the intestinal connections can leak fecal material or the ileal conduit may leak urine into the peritoneal cavity, he or she observes for and promptly reports symptoms of peritonitis, abdominal tenderness or distension, fever, and severe pain. Management of the urinary stoma is similar to management of a fecal stoma. See Chapter 48. The skin needs protection, the surgical dressings must be changed promptly when they become wet, and the appliances need care and cleansing. Each time he or she changes a temporary drainage bag, the nurse inspects the skin around the stoma for signs of infection and skin breakdown. Continent urinary diversion, called a COCK, K-O-C-K pouch, or an Indiana pouch. The nurse inspects the stoma for bleeding or cyanosis. He or she may irrigate the pouch if ordered to prevent mucus plugs or blood clots. The nurse teaches the client how to perform intermittent self-catheterization. Initially, this is done every 1 to 2 hours, but eventually will be performed every 4 to 6 hours. Ureterosigmoidostomy. A catheter is inserted in the rectum to drain urine continuously. The nurse checks the amount and color of drainage from the rectal catheter every 1 or 2 hours and inspects the anal and gluteal areas for signs of early skin breakdown. The catheter is removed when peristalsis returns. Because the sigmoid colon reabsorbs urinary constituents, clients are prone to fluid and electrolyte imbalances throughout the post-op period as well as for the rest of their lives. Observation for signs of electrolyte losses is essential. The nurse teaches the client exercises to improve sphincter control. Once good control is achieved, the nurse instructs the client to void rectally every 2 hours to prevent reabsorption of fluid and electrolytes. Clients must never have enemas, suppositories, or laxatives. This is the end of the slideshow. A patient is suspected to have bladder stones. How many hours should a urine sample be collected for as part of the diagnostic workup? A is 6, B is 12, C is 18, or D is 24. And you should have answered 24. A 24-hour urine collection is part of the diagnostic workup for suspected bladder stones. This is the end of your lecture.